Yes, I can see your slide, bridging the gap, overcoming resource challenge.
My apologies.
Thanks, Dr. You can proceed.
Yes, so this is my last slide. And this slide is on bridging the gap. So just asking ourselves, how do we overcome the challenges that we have in our region in terms of providing care to our patients? We find that in our region, we face severe specialist shortage. We have the late disease presentation, which presents as delayed care. And then we have the fragmented HIV urological care. And we can bridge the gap by having this three-pillar system. One is on system integration, where we embed the LUTS screening in our HIV care clinics and even in our non-communicable disease clinics. Two is on the use of digital health platforms, where we confer or consult over some of the platforms that we have, and also use some of the forum like we have today to pass on some of the information. And pillar three is on policy and capacity building, where we align ourselves with some of the available policies, like the Kenya Healthcare Professionals Policy, to expand the workforce so that we can promote early and on-time patient care. We will never have enough urologists, nephrologists, diabetologists for taking care of our patients. These are the key takeaways. One is for males, we should look beyond the BPH when you're assessing the patient. The bladder is a key player, and also the systemic health for the patient. Screen the vulnerable populations. We've seen those that live with HIV. Those that live with non-communicable diseases also require proactive assessment. Three, address the patient holistically so that we can try and break down some of these stigmas and barriers towards patient care. And four is to tailor the treatment. Use the evidence-based guidelines that we have for patient management. And as much as we talk about watchful waiting, pharmacotherapy, surgical options, let's remember to consult and refer when necessary. Thank you.
Thank you so much, Dr. Nderitu. That was a lovely presentation. I think it was very precise. You have well discussed the topic of lower urinary tract symptoms in terms of what they are, who are the likely people who we need to actively look for, what are the tests we need to do, who do we need to refer, what basic information can we give them even as we're referring them in terms of, what are the expectations, what are the types of medications, and also who also require surgery, so that sometimes, a patient is not being managed as basic LUTs, and yet, they're having indications that require escalation of care. I think we apologize also for the interruption, but I think most of the presentation had already been done, and the key points are also emphasized on this page. And now we open the floor for questions. And before probably I read the ones that have been projected, I'll start by the first one. You mentioned in the presentation something about double voiding. I don't know whether you would like to explain what that is, because maybe quite a number of us are not familiar with the term double voiding.
Yes, thank you, Dr. Ari, for that question. So it's one of those behavioral techniques where you ask the patient or the individual when they pass urine, they should wait 10 to 30 seconds, and then they try to void again. So that ensures that they're emptying their bladder more, so that they are reducing what we call the post-void volume.
Okay. There are patients who mention that if they use a toilet seat and sit on the toilet, the voiding is easier. Does that help?
Yeah, there are those patients who say that it's easier, and that is based on your anatomy. A full bladder tends to extend into the abdomen. So sitting down as you're flexing your hip, you're applying extra pressure on your bladder. So that helps expel the urine out of the bladder. That's what I'd say about those who sit versus those who stand.
So we'll go to the first question, and this also is something that we see. We see patients. So the question was about a middle-aged man who does not have lower urinary tract symptoms, but has an incidental finding of a high PSA with an ultrasound just showing mildly elevated prostate volume. Is that a patient of watchful waiting, or that's a patient who already needs to be seen by the urologist?
Thank you for that question. I think I had that point on one of the slides, and that is one of the red flags that we say if a patient has a high PSA, that's a patient you send to a urologist because they'll need further evaluation because they may be presenting with prostate malignancy.
Okay. So we do have also patients who, if we ask them, do they have lower urinary tract symptoms? And probably the basic screening, they say no. But, when as part of, the evaluation, when we send them for tests, they have, pretty high PSAs. So does that mean that there's some patients, unfortunately, who can have even prostate cancer with no subjective feeling of lower urinary or voiding symptoms, so to speak?
Yes and no. Yes, in that for this individual who has a high PSA who may have prostate malignancy, it doesn't necessarily mean that they will have an enlarged prostate. And then again, no, in that an enlarged prostate does not equal to having lower urinary tract symptoms. You may have a patient who has a 40-gram prostate and another patient who has an 100-gram prostate. And the 40-gram prostate has worse symptoms than the one with the 100-gram prostate. So it's patient by patient basis. And that's why I said you have the tool, like the IPSS, which is a validated tool. And it's objective in that the symptomatology, once you grade the symptomatology, you're able to approach management or further investigation based on each individual.
Okay, thank you for that. This is about medication. Some patients discontinue alpha blockers due to dizziness, postural hypotension, or ejaculatory side effects. What alternatives do they have, or sort of combination approaches? Because there's, that can improve probably tolerability or adherence, or, and the other issue is we do see, for example, patients who have been seen by their urologists, they have been put on medication, and for some reason, they said the medication was for 1 month, then they stopped taking it. So what are the expected durations, so that maybe as we encounter them, we also tell them that it's important, continue your medication as you continue the follow-up with the relevant, doctor.
Yes, some of these drugs that we prescribe to the patients have side effects. And it is important to explain these side effects to the patient. And as you've rightly said, you have some of those who have dizziness and lightheadedness, usually occurring when a patient is standing up. And this is usually highly or is mostly reported, especially after the first dose. So usually it may subside with subsequent medication use. Two, we have the ejaculatory changes. Retrograde ejaculation has been reported. And we may have other symptoms like the headaches and palpitations, others like nasal congestion. And some of these symptoms, like I've said, they're reported after the first dose. And they may subside with subsequent medical use. But then again, you may also advise the patient to take these medications in the evening, just before bedtime, to prevent some of these issues that are hindering their daily activity. Again, as you prescribe the medication, assess for any other medication use so that you assess for drug interactions. For example, those patients who may be on antihypertensives. Um, Last but not least was on the, if you may remind me.
Duration of use, are they supposed to use them 1 month, 6 months? Is it long term?
Yeah, I that is a question we get routinely, and it's difficult to when you're introducing the medication to the patient. It's difficult to tell them that this drug you're going to be using it on a daily. So we usually prescribe for a month or 6 weeks, so that the patient may appreciate the response. Like I said, the alpha blockers usually have a response within days. The peak onset is between day 3 and day 5. So after a week, they describe positive response. The 5 ARIs usually take longer, months to have an effect. So for that patient who will have a combination, who you're giving a combination therapy, you may have to give longer for them to appreciate the effect of the medication on their urine flow. Um, Medical therapy is a daily, they're supposed to take the medication on a daily, they are OD doses. And so this is something that you can discuss with the patient in subsequent clinical visits. At the beginning, if you tell them it's lifelong, it might deter them from taking the medication, also because of finances. So I think these are discussions that you may have with the patient in subsequent clinic visits.
Yeah. Um, so we do see quite a number of male patients, for example, who have diabetes, and the diabetes also significantly affects their urinary symptoms because of the osmotic symptoms that are associated with diabetes. So um, even on the emphasis in terms of the assessment, looking for also metabolic causes like diabetes, checking for uh, urinary infections. I think quite a number of these patients we do find, in fact, having both an infectious process going on, again, because the diabetes also predisposes to that. Then the high sugars also causing osmotic symptoms, and unfortunately, they also have either an underlying enlarged prostate or neuropathic problems that are also contributing to the lower urinary tract symptoms. So, as you've said, sometimes it can be a complex interplay, and it requires a multidisciplinary approach. Um, So another question here talks about given the fact that some of these patients come with concurrent sexual dysfunction, how is that approached?
Very good question. Thank you for that. Yes, we have described these symptoms in the aging male. So the aging male will also have other concurrent conditions. Just like Dr. Omari, you've rightly talked about, this patient also may be having other conditions like diabetes. They may also present with erectile dysfunction. Now, the interesting thing is that the erectile dysfunction can be treated by medical therapy. And some of this medical therapy that manages erectile dysfunction, that is the PDE5 inhibitors, has also been shown to have some action on the prostate. So you find that treatment for erectile dysfunction, the PDE5 inhibitors have a synergistic effect or response in terms of managing prostate disease, that is BPH. And you find in the market sometimes, or in the market, some companies have combined like the alpha blocker with a PDE5 inhibitor. That is to manage both the prostate and the erectile dysfunction issue. But then again, it's been shown that the PDE5 inhibitors have a holistic or a synergistic effect on treatment of prostate disease. Are you there, Dr.
Sorry. Uh, so an extension to the question, how long till resumption of normal sexual activity?
That is that is patient dependent. Depends on whether there is any other etiology that may be causing the sexual dysfunction. If it is the medical therapy from some of the diseases like diabetes, you find this is a situation that the patient may have to live with and maybe get management as well as the other conditions that they are being managed. So it's just one of those conditions which presents together. For example, like diabetes and hypertension. So we've been told that in some individuals, the individual who has diabetes may have a hypertension. It is also the same for an individual who has a prostate disease. They are likely to have erectile or sexual dysfunction. So they are both managed in the same instance, and it is not a condition that you treat and you say the issue has been cured. No.
Thank you for that response. I think we'll take one more final question. In a case of BPH and a patient with hypertension, so the question is about, is there a code of practice when introducing the medication for BPH? Do we drop antihypertensives and monitor BPs, or we just introduce? I don't know, maybe you give your take and I'll also give an input to this one.
I don't know whether that's in relation to what we were talking about in terms of the dizziness and the lightheadedness, but
Yeah.
yeah, so usually the BPH medication does not directly affect the blood pressure levels. The dizziness and lightheadedness just we say it's orthostatic, and that's why when we're introducing the drug, we recommend that the patient takes the drug at bedtime. That is just to try and manage that fast dose effect of the syncope that the patient may report. So I do not think that you should manage BP fast so that you can introduce the BPH medical therapy. I don't think that is an absolute indication.
So I think probably my take on this is probably that the person asking is asking about if this patient is already on blood pressure medication, then they require medication like the alpha blockers. Do we need to, for example, drop some of the other blood pressure medication, or do we just monitor the blood pressure, or do we just introduce these these medications and monitor? I think from what I have seen in clinical practice, most patients, their blood pressure medication is not necessarily reduced, but there are patients who also have, we like call it significant variability in how their blood pressure behaves. So, and especially probably our older patients, quite a number of them already experience some level of postural hypotension, especially if they're going to be on diuretics, or our patients who already have, some level of heart failure. So sometimes introduction of the alpha blockers can actually, make their dizziness to persist, or their postural hypertension almost to persist. So they mentioned that, apart from at initiation, the symptoms are 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 persisting. And that this such high risk individuals, I usually say it's a good idea that they monitor their blood pressure, and then we see whether, going forward, is it worth having a reduction in their blood pressure medications if that's the kind of scenario that the patient is facing. I think if I look through the questions, I think we have tried to answer the questions that we received as much as possible. I know such a topic about lower urinary tract symptoms can be quite, it can be quite big, and we might not be able to discuss everything about it. So we would like to thank Dr. Dr. Anthony Nderitu once again for hosting us and just teaching us a lot about this, especially in males, highlighting the gaps that we need to fill. I think one other thing he emphasized is that, evaluation of LUTS requires urine examination, a picture, to also evaluate the urological system, because quite a number of patients don't get a picture. And then, by the time we are seeing them, they're already having renal dysfunction. So we are hoping that our screening will be appropriate. Somebody has already proposed in the next class we should talk about male infertility and varicocele of the testicles, the management, the tests and management outcomes. Thank you for your feedback. I think I'll hand it back to Zippy. She had a poster that she wanted to share with us. The Kenya Diabetes Study Group will be having a conference, our 11th conference in June, from the 17th to the 20th. And we are hoping that you'll be able to join us so that we can discuss more about diabetes. Is there anything else you wanted to mention, Zippy?
Thank you, Dr. Omari, and thank you also, Dr. Nderitu, for the excellent talk. Yes, as you've mentioned, our conference is coming up in June on the 17th, and it will be at the Lake Naivasha Resort. So registration is still ongoing, and we hope that we'll have the participants who've joined us today joining us for the conference. So let me just put it up and then you can see the details. In case you need any information, feel free to reach us at KDSG, or you can look into our website to get more details. Thank you.
So on behalf of the KDSG committee, Education Committee, we would like to thank you all for participating, for your insightful questions. We want to thank the Kenya Association of Urological Surgeons for partnering with us and spending this time teaching us. We don't take it for granted. And we are looking forward to further collaborations. You can also invite us to your Urological Association webinars, and we will be happy to teach also about diabetes. Thank you so much and have a good evening.
Good evening. Thank you.